Hi there, it's Randall Cooper here, and welcome along to another live video. This time I'm with Adam Culvenor. I'm actually not with him, I'm talking to him from the other side of the world. I'm sitting here in my home office, and we've got Adam all the way over in Austria. Adam, welcome along to the session.
Hi, Randall. Thanks very much for having me.
Now, tell us a little bit about why you're in Austria at the moment.
Well, I'm over here after I finished my PhD in Australia, and after being awarded my PhD back there, I applied for a postdoctoral position, and one of them was through the European Union, which is what I'm involved with here in Austria, in Salzburg, is a big European Union funded project called NEMO,
Right.
which involves basically 8 different universities around Europe, and we're basically tasked with the goal of working towards the right treatment for the right patients at the right time for people with knee osteoarthritis. So there's many different PhD students, I think about 11 in the program,
Yep.
and then there's 4 postdocs as well, which I'm one of.
Okay.
So I've been lucky enough to come over here and enjoy a European escape, which has been fantastic.
Now, your area of interest is in particular in the osteoarthritis in the patellofemoral joint after ACL reconstruction, is that correct?
That's right, yeah. So that's what my PhD was focused on back in Australia. So looking at younger people post-injury, particularly ACL injury and reconstruction back in Australia.
Mm-hmm.
And so my work over here is a little bit related and an extension of that, which is looking at more the older people with the non-traumatic knee osteoarthritis and looking at risk factors for the development and progression of that. So they do sort of intertwine a little bit, but slightly different patient populations through life. Yeah.
I mean, it's such a big thing. I think that the osteoarthritis after an ACL reconstruction is gaining more and more attention, and justly so, because it's such a serious kind of condition later in life. Why do people get arthritis after an ACL injury? We'll talk about an ACL reconstruction at this point.
Sure. So I suppose much of the focus on ACL reconstruction has been on that immediate post-operative phase, so rehabilitation, back to sport. That's what young athletes and people who suffer an ACL injury and undergo surgery typically are focused on. But unfortunately, there are long-term consequences involved with an ACL injury, and irrespective if these people undergo surgery or not. And one of those quite serious consequences for many people is post-traumatic knee osteoarthritis. And this can happen in people as early as 5 to 10 years after having the injury or reconstruction. So typically people are in their adolescence and in their 20s when they're having an ACL injury. So 5 to 10 years later, it's still only, people are still less than 30, less than 40 years old. So it's affecting young people who have still working and have kids and want to pursue sporting activities. One of the reasons why we think it's such a big problem, and there's still a lot of research going on in this area, is potentially the trauma at the time of injury creates a cascade of events, if you like. So you're getting a lot of not only injury to your ACL, but often injury to the meniscus, and that's one of the main risk factors for those people who go on and have osteoarthritis, and also to the cartilage. So in my looking at the patellofemoral joint, we know that people who suffer a cartilage lesion to the articular cartilage at the time of injury or after, they're much more at risk of developing that post-traumatic osteoarthritis later on. And other things like muscle strength, it does take a long time to get that muscle bulk and strength back after reconstruction. So that can influence biomechanics. We know that reconstruction and the injury itself changes the knee biomechanics. And so if we're going back to sport and high-level activity levels with slightly different loading through the knee, then the cartilage and bone can be loaded in areas that aren't typically loaded and create this a setting for problems later on. So there's a number of reasons, and I think optimistically there's some that are modifiable. So as physiotherapists and clinicians, we can go in and help these people. But certainly there's still lots of work to do to identify these people who are more at risk particularly.
There's a school of thought at the moment that, like you did mention about the mechanical trauma at the initial injury, and then there's the altered biomechanics. Weakness is obviously a factor that can contribute to some people as well. But the thing that's gaining some traction at the moment is the influence of ongoing inflammation slash synovitis in the joint, and whether those substances that float around the joint for prolonged periods may actually accelerate any degenerative change in the joint. Two parts to this question. I mean, is there any research or any kind of published research on that at the moment? And B, what's your feeling? What's your clinical opinion on it?
Yeah, I don't have particular expertise in the sort of biochemistry and synovial fluid makeup and things like that, but I do know that the injuries at the time of injury, it's certainly quite a significant injury, and it does create this cascade of events, almost an explosion, if you like, that is thought to have longer term consequences. Unfortunately, the inflammation doesn't sort of differentiate where it affects the knee. So the patellofemoral joint, which is at the front of the knee, is within the synovium, and the synovial fluid certainly gets there. So the thought is that these biochemical markers of inflammation can often soften the cartilage.
Yep.
Which then, if we go and return to sport at a time when we're not quite ready for that, then in the setting of already softened cartilage from these synovial markers, then that might just be the tipping point for somebody who doesn't have the optimal biomechanics or the optimal strength, which if we didn't have those synovial markers present, they might be okay. But because we're getting a whole abundance of risk factors involved in the same knee, then maybe that's what's tipping these people over the edge and creating that nasty-looking knee. We know that synovial inflammation is definitely associated with quite a lot of pain, one of the most potent sources of pain in the knee. And I think from a clinical perspective, I don't have a lot of evidence necessarily to back this up, but I think that sort of angry knee post-operatively is really hard to settle down. And these people, I think, often have a lot of restrictions in their range of movement too, and become stiff. And I know stiffness and that sort of angry knee setting is difficult to treat as a clinician early on, and can be driven by a lot of pain. But I think that's really important to longer term outcomes, is while the knee is in that sort of acute phase and a little bit mobile before it becomes very stiff, that we actually do reach full range of movement, because that's actually another risk factor for long-term problems and osteoarthritis, is having stiff knees. So I think there's a number of factors that sort of go into that without being an expert and knowing the literature back to front.
I like the term that you use, angry knee, because you do see that as a clinician. You encounter people who have a lot of trouble kind of settling things down, and they're invariably the ones who tend to give you most trouble for the remainder of their rehab. But then they can kind of come back years down the track, and they can that angry knee, whether it's fluid in there, pain. It's not only softening the cartilage potentially, as you mentioned, but you get the muscle inhibition as well, and then you get the kinesiophobia, and it's all a negative cycle. So I think that, your term that you use actually is a really nice one. The interesting thing, and next question for you is that, again, a lot of the theory is about that the tibiofemoral joint and how the things are affected with the tibiofemoral joint, but the patellofemoral joint kind of got away scot-free there for a long time. However, one thing that you guys have done such an excellent job at is pick up that the arthritis that develops in the PFJ is just as bad, if not worse, than the tibiofemoral joint. And I'm interested to know why that is. Why does the PFJ get it more than the tibiofemoral joint?
It's a really interesting question, and one that I've grappled with, having found that it is a problem in these people after reconstruction, certainly just as much as tibiofemoral osteoarthritis, which is, as you mentioned, by far and away the most studied joint within the knee. So I have a few theories, and some of them have a bit of evidence behind it. But the first one, as I sort of mentioned with the initial trauma, we know that articular cartilage lesions can occur not only in the tibiofemoral joint at the time of trauma, often in the lateral compartment through that kissing type of mechanism when the mechanism of knee valgus occurs. But the same thing also happens to the patellofemoral joint. So we see a number of patellofemoral cartilage lesions, which we know increase the risk of post-traumatic osteoarthritis in the long term. Another hypothesis is potentially those people who have meniscal lesions and undergo a meniscectomy, that changes the alignment. So if you're taking part of the meniscus out of one side of the tibiofemoral joint, over the long term, that can actually reduce that joint space a little bit. And we know that the frontal plane alignment and the so-called Q angle is certainly related to how the patellofemoral joint moves, how it's connected to the hip and the foot. And that can just slightly offset the alignment within the trochlear groove where the patella sits and can create that environment for possible increased load in the lateral compartment of the patellofemoral joint in particular. But also, particularly following a patellar tendon graft, which is quite common, we know that you take some of the patella during the surgery, so that can alter, obviously, the extensor mechanism and the function of that extensor mechanism and patellofemoral biomechanics. So we found in one of our papers in the review that patellofemoral OA was very common after patellar tendon autograft, but almost nobody had studied patellofemoral osteoarthritis after a hamstring tendon autograft. So we actually performed a study looking at whether patellofemoral OA was still a problem after a hamstring graft and found that the prevalence of OA in the patellofemoral joint more than 5 to 10 years after having surgery was just as common in following a hamstring tendon graft, patellar tendon graft. So which suggests it's not necessarily that graft and the extensor mechanism dysfunction, if you like, that's really driving that. So I'm sort of more leaning towards the biomechanics. So we know that after surgery, after injury and even after surgery, the biomechanics of the knee changes, particularly towards an external rotation offset.
Yes.
And if you're externally rotating the tibia, even if it's 5 degrees or less, which is typically the figure that's put out in the literature, the patellar tendon is attached to the tibial tuberosity, which is obviously part of the tibia. So if you're moving the tibia laterally, rotating it, then the patellar tendon sort of realigns, which is attached to the patella, and that sort of has an influence on the rotation and the tilt of the patella, again, in that really tight groove that it sits in. So I think, as I mentioned earlier, as people are going back to sport, and if they don't have optimal biomechanics and strength as well to support the neuromuscular control of the knee, that we're sort of setting up this sort of situation where we're endangering not only the tibiofemoral joint, but I think we're realising more and more now that the patellofemoral joint is just as much at risk. And importantly, we see that it's more and more associated with pain, even more so than the tibiofemoral joint, which highlights the need for clinicians to really focus on that joint as well.
Yeah, talking about patellofemoral pain, I mean, if you, and I'm sure you do, reflect on what has been studied recently and also the evidence behind what contributes to people with patellofemoral pain, i.e. lack of quad strength, lack of neuromuscular control. Hip strength is the thing that's kind of been coming lately, and there's some biomechanical things in there as well. Those things, I assume, should be applied to a post-operative ACL to try and help reduce the stress and the force on the PFJ after an ACL injury and reconstruction. Would you agree?
Yeah, exactly. There's been, again, I think it's really well known that anterior knee pain is one of the really most important and troublesome complications in the acute phase after an ACL reconstruction, and probably more so with the patellar tendon, but also very, very common after a hamstring tendon. So I think using our knowledge in treatment for non-traumatic patellofemoral pain, so what we see in typical patellofemoral pain syndrome type patients, we can then translate that evidence across to those with an ACL injury and reconstruction. Again, addressing hip dysfunction, which we know is becoming a big problem in these patients, and addressing local factors such as strength and alignment, taping if we need to, and also possible factors of the foot, those distal factors as well. So, yeah, I think trying to minimise the immediate post-operative anterior knee pain in that setting will hold in good stead longer term. And I think there's some evidence that have been published from a group, I think, in Europe that has looked at modifications of different types of exercises and the load that they put through the patellofemoral joint. So suggesting that things like a wall squat, typically we might get patients sort of squatting against a Swiss ball or against a wall with their back against the wall, has been shown to actually increase more so the patellofemoral stress than, say, a squat freestanding. And same thing with the lunge. If we're lunging too far forward with that knee over the toe, then that puts more stress to the patellofemoral joint than, say, a lunge that just keeps a good alignment with the knee over the toe, not going further forward. So there is some evidence out there for clinicians to use to try and reduce the detrimental load to the patellofemoral joint. And I think we can transfer that type of evidence after ACL injury to that population as well, to try and minimise this pain that's quite common during rehabilitation.
I do want to talk to you about your study in a minute, but I've got one more clinical type question for you, and that is about is there any ability to clinically pick up the people that are going to develop arthritis down the track? Is there anything that we can do with someone who may be a year or two post ACL reconstruction, who there are red flags on them for having a degenerative knee down the track?
Sure. And I think that's the real ultimate question for us as clinicians. If we can identify patients who are going to develop OA longer term, if we can identify those people earlier, then we can tell them and empower them and say, let's do something about it now. So there are a number of clinical tests which we can arm our toolbox as clinicians early on during our rehabilitation phase. And one of those is simple tests like single leg, the hop for distance test, which we often use as return to sport criteria in our package of tests. And people who, at 1 year after reconstruction, if patients haven't returned to a one leg hop for distance of at least 90% compared to their other leg, which is typically the discharge criteria we use, then we know from evidence from Sydney, actually, with Leo Pinczewski's work, that these people are more at risk of developing tibiofemoral osteoarthritis 10 years later, so 10 years after reconstruction. So we can then tell our patients, look, you're hopping, your function's not great, you're more at risk of developing OA, let's do something about it now so that we can try and reduce that risk. And other simple tests that we've done in our research group, such as the single leg rise, which is the number of sit to stands, if you like, on one leg from a plinth where the knee's at about 90 degrees of flexion. If patients are unable to do 22 of those on their reconstructed leg, then that suggests that there's an increased risk of developing symptoms over the next 2 to 3 years. So again, 1 year after reconstruction, this test indicates those people who develop worse symptoms, but also those people who develop OA about 5 to 6 years after reconstruction as well. So, and we know also that the quadricep strength in particular increases the risk. So we can, if we have the capacity and the equipment to measure the strength in a reliable, one valid way in our clinic, we can do that and make sure that it is back to the other knee before discharging these patients back to sport, and also empowering them to say, well, that's actually good for your long-term joint health as well. So I think there are a number of tools that are really useful for clinicians early on in that stage where we can help our patients assess the risk longer term.
Yeah, I think that all sounds good. And I think actually kind of, one of the things that's been researched more heavily in recent years is that discharge criteria, return to sport assessments. There's been a big spotlight that's kind of focused on that in recent times. And part of that is to ensure that people do complete their rehabilitation. And I've always felt deep down, having seen a lot of these injuries for a lot of time, is that a lot of people who do have those degenerative changes down the track are the ones who have incomplete rehabilitation early on, and then probably go back to activities that they want to go back to but shouldn't go back to, particularly being in a weak and poor neuromuscular state. So it sounds like the research is kind of focusing on that area, and that dovetails in beautifully, I think, with most people's clinical experience.
Yeah, exactly. And I think as a general sort of overarching idea, I think as physios, we do very well early on in the post-op phase with increasing range of movement, increasing strength. But I think that late stage, high-level neuromuscular control, as you mentioned, and return to sport, specific type drills, we maybe don't do as good a job at. And I think maybe the system where particularly a lot of our patients are privately funded coming in to see us, then they get to a level that they can run pain-free and they think they're back to normal, where if we actually go and delve into their clinical and functional capacity, there's a lot of deficits still which they don't necessarily realise, and we miss those sort of patients because they stop coming back to us. So I think that's a real area where we can certainly focus on.
Yeah, I furiously agree with that one. We've got some exciting news because you've recently been awarded a NHMRC fellowship. So congratulations, Adam. That's just terrific.
Thank you very much.
And it's terrific for not only you and La Trobe University and where you are in Austria, but it's also great for the public as well. So tell us a little bit about your fellowship and what study that you're going to do, or studies that you're going to do as part of that.
Sure. So thanks very much to start with. So the application and the project that I'm going to do is the first 2 years of the 4-year fellowship. I'll be based over here, so continue my work in Salzburg, in Austria, but be more focused on the ACL reconstruction and injury type of research. So over here, I'm going to collaborate with a group from Sweden who have performed, and many of physios and clinicians and listeners will be aware of this study, I'm sure, the Canoon study, which is the first real randomised controlled trial in the world.
Yes.
That has looked at the benefit of a reconstruction above and beyond just conservative rehabilitation. So is reconstruction, injury with a reconstruction, better for short-term and long-term outcomes than purely rehabilitation alone? And those first couple of studies have been published from that data set. But what I'm going to be using and collaborating with them is looking more at the joint health, so specifically the patellofemoral joint, continuing my work from my PhD, and looking at whether patellofemoral joint cartilage during the first 2 and 5 years after injury or reconstruction, depending on which group these patients are in, and how that cartilage changes. So whether it thins, whether it swells because of fluid, and that's possibly a detrimental outcome as well.
Yep.
Here in Salzburg is one of the reasons why I'm going to be staying here, is I'm working with a group here who are real experts in image quantitative analysis. So they do a lot of work with cartilage segmentation and cartilage volume, thickness, thinning, and real leaders in that area. T2 mapping and relaxation time of cartilage, which is really growing in the area of early osteoarthritis, and trying to pick up changes in cartilage really early in these young patients.
Is this using MRI?
Yeah, so all of these patients have had MRI taken preoperatively if they underwent surgery, so just after injury. They had MRI taken as 1 year after injury, or 6 months, 1 year, 2 years, and then 5 years. So a really rich data set which we can go and track the trajectory of these knees in the short term and medium term, and I know that there's ongoing follow-up of this cohort as we speak. So I think that'll really tell us a lot of information about how the cartilage behaves.
Yep.
And also, from my perspective in particular, was looking at risk factors, as we sort of talked about earlier, is identifying patients early on that are at risk of this accelerated cartilage loss and thinning and potentially swelling, we'll see, to try and, again, the ultimate aim is to stop these patients from developing osteoarthritis. So I think if we can get in as early as we can, then there's more chance before these changes become really degenerative, old and yucky and non-reversible. So that's the aim over here.
And then that's the Salzburg part of it, and then you move your study back home to Australia, is that right?
Exactly. So the fellowship's the 2 years over here, and then the 2 years back at La Trobe University, which is fantastic to be joining the team there and the Sport and Exercise Medicine Research Centre there, which is fantastic. And my work there will continue the same theme and bring back to La Trobe and Melbourne those skills in image analysis, and work on a cohort there that we've been working on for quite a number of years from my PhD, actually, which is people who have undergone reconstruction. And we have a number of tests. So we have functional clinical tests in these patients at 1 year after reconstruction, MRI, which I'll be using. We also have biomechanical tests, which I think is really important, as we mentioned earlier, with biomechanics being one of those potential factors leading to this osteoarthritis problem, that we can then use the imaging software, MRIs at 1 year. We're currently collecting them at 5 years, these patients. So we've got long-term data and then really looking at the trajectory again at cartilage loss in the patellofemoral joint, but this time in Melbourne, really matching it to and associating it with potential biomechanical factors, clinical factors, and functional outcomes. So really, as I said before, really just keep working towards trying to identify these patients. If there's particular subgroups or phenotypes of patients that are more at risk, then being able to arm ourselves with that knowledge and intervene in these people to help them. Yeah.
Well, you can see why the NHMRC have actually gone with your project, because it is. I mean, as a physio, we see. I see just as many patients who are 10 or 20 years after an ACL reconstruction as I do right at the time, and you do see the second half of the ACL is always quite well known and famous, but the degenerative effect is just as debilitating and life affecting. So, congratulations on all your great work so far. Good luck.
Thanks a lot, Randall.
Good luck for the study that's about to happen, and I thank you very much for joining me for a chat today.
No worries. Thanks a lot for having me.
All right. Thanks again, Adam.
Cheers.